Okay, good morning. I think we'll go ahead and get started. Thank you all for joining us this morning. I'm just going to go over a couple of housekeeping items for folks to keep in mind. So the session this morning is going to be in a webinar format. So right now your cameras and microphones are currently turned off, and they'll stay off while the presentation is happening. We are recording each session, so just be aware of that. At the end, we're gonna post all of our sessions onto our website so folks can share that with colleagues or refer to it later if you're not able to join today. So I do want to encourage you to ask questions along the way for our presenters, but please use the Q&A tab that you should see at the bottom of your screen. I want to try and put all the questions in there, and then we'll use the chat function just for comments. Please feel free to let us know who you are, what organization or group you represent. Please feel free to use that for networking as well. But if you have questions, please try to put all those in the Q&A. I'll manage those at the end of the session. When our presenters are done, we can go through those. And then if we have time at the end, we'll open up the floor to have more of a dialogue. So the way that we'll do that is if you want to ask or make a comment directly, just use the raise hand function and I'll call on you and then open up your microphone so that we can then talk. The panel slides will be available later on. I'll send that out to everybody as a PDF probably in a week or so. If you have more questions for me or the presenters after the session, please feel free to email us. We'd love to continue the dialogue. And I'd love to hear feedback from folks. This is the first time at the coalition that we're doing a series like this, so I'd love to know what went well, what we can improve, and as I said, this is our first session in a series of 6 that we're going to host on this topic. We're actually going to skip December, and we'll pick up again in January, and we'll run through May, and then I'll give you the date of the next session in a couple of minutes. And then just as a quick aside, this topic of housing barriers for justice-involved populations and those at risk of overdose is quite broad. And so I just want to put a little caveat out to folks that not every learning collaborative that we're going to do will deal explicitly with housing interventions or housing solutions. Part of what we're hoping to accomplish with this series and this project is really to provide a broad array of information and education around a pretty difficult and challenging subject. So just please be patient. We hope that you'll come back because we will have sessions that are solely focused on housing interventions and housing solutions, but we also want to try to really kind of step out of our own sectors and learn a little bit about some other sectors that we may not know a whole lot about. So without further ado, I'm just going to give a very brief overview of the project, and then I'm going to hand it over to our friends at the North Carolina Healthcare Foundation. Okay, so allow me to introduce myself first. My name is Alex Rubenstein. I'm a housing fellow with the North Carolina Housing Coalition. I came on to the coalition in the beginning of 2022 to help lead this project. This project, again, is focused on housing barriers for people who are justice involved and individuals at risk of overdose. And so this project is funded by a CDC COVID recovery grant that the North Carolina Division of Public Health Injury and Violence Prevention Division applied for in 2021 and then received. And so we started talking to them in 2021 about how we could work collaboratively together. And this was the topic that we felt was most crucial in the moment. And so this project will run until end of May of 2024. And in case you're not familiar with the North Carolina Housing Coalition, this is just sort of our brief mission statement about what we do. Again, we're primarily focused on housing advocacy, research, policy, and coalition building. We are focused on both, federal housing issues, state issues, and local issues as well. We host a weekly podcast, Housing Call. That's a really great way to stay informed about what's happening both in North Carolina and at the federal level. So I'd really encourage you to join that call weekly. If you are not already on it, you can access that via our website. And so let me just give a very brief overview of the project. I won't read each bullet line for line, but just to give you a sense of kind of how we broke the project up and kind of the key things that we were looking at. So I would say, one of the two big bullets that was really important for us to understand and know better in the beginning of the project last year was to really look at the intersectionality of these populations and also try to map out and understand the multiple systems that people are coming into contact with. So, looking at not just the issue of housing and sort of where folks were showing up within the housing sector, but better understand what it looks like for folks coming out of, say, the justice sector or public health or hospitals, et cetera. And then the second big bullet that we were really trying to learn more about in this first year was gauging what kinds of cross-sector collaboration might be happening across the state to improve access both to housing, but to healthcare, to supportive services, right? So we were looking extensively at, what kinds of sectors are collaborating with each other to address this issue. And so then for the first year of the project, we worked with the Technical Assistance Collaborative. They're an amazing TA firm that does a lot of focus on housing, community development, et cetera. And so they were really instrumental in helping us get the project up and running for the first year. And the first year really culminated in a landscape analysis report that we wrote. And we're going to make that report available on our website in the coming weeks, so you can check that out. And then as we get into the second and third year of this project, we sort of have been pitching as our sort of outreach and advocacy year. So we're working on developing a set of educational materials on the subject that are really digestible, sort of looking at, creating 1 to 3 page materials that folks can share throughout their networks. Again, touching on a lot of different topics within this area. So not just about what kinds of housing interventions are necessary or what kinds of barriers need to be lifted. We're looking at really a wide range of issues. And then I would say that the second big bullet of things that we're really trying to engage people around is all the opioid settlement money that's come to North Carolina. There's a lot of it's very unprecedented, really. And so we're trying to engage communities around opioid settlement funds. We'd love to know how communities are choosing to use their funds, what sorts of potential housing interventions can be funded with the settlement money. So that's been a key topic for us this year. And then finally, we're hosting these 6 collaborative sessions. So really excited to have everybody here this morning. I'll just give a couple more bullets on the project. Okay. So for our landscape analysis, we did a lot of qualitative interviews. So we did roughly 74 interviews among 50 organizations spanning multiple sectors. I won't, read these line for line, but this gives you a sense of some of the folks that we were talking to. And our goal, again, was really to try to look at this from, a 30,000 viewpoint and really understand what kinds of systems people are coming into contact with, what kinds of systems are already collaborating with one another, and where do we see gaps. These are just some of the bullet points that we received in our interviews. I think a lot of these are probably not earth-shattering to folks. Again, we know that there's a general lack of housing for these populations. Oftentimes, housing that is available is often non-permanent. So folks are living in very temporary situations, or they're having to live in congregate settings. And oftentimes there's a lot of barriers for folks who either re-entering or people who are at risk of overdose. One of those key collaborative questions we had was really around local reentry councils and continuums of care. And so while we did find that there are lots of LRCs and COCs that are beginning to collaborate, sometimes each of those sectors is not really well versed on the other and not necessarily well versed on kind of what resources are available through each sector. Okay. We Again, this is not going to be earth-shattering to anybody, but in general, we need a lot more funding, and we need that funding to be really flexible. So sometimes some of the barriers are really at the administrative level and sort of the bureaucratic level. And then the only other bullet I want to highlight here is that, there was a resounding acknowledgement that Medicaid expansion would be incredibly important. And just one of the bullets that I have here is just about the availability of peer support and what Medicaid can do to help fund that. But that's definitely a theme that comes up again and again. And so, of course, we know that Medicaid expansion is happening here in North Carolina. I think we're all really eager to see what that rollout is going to look like. But we know that that's a big positive for us. Couple of other bullets just within our landscape analysis, the risk and severity for folks who are either formerly incarcerated or struggling with addiction and at risk of overdose. They're at such high risk for both experiencing homelessness, rearrest, and overdose in particular, especially coming out of institutionalization. And so I know that's going to be a theme in our presentation today. And then last bullet here, I just want to really point this out that, this issue disproportionately impacts individuals and communities of color. And I think we need to just, remember to keep that in mind as we're doing this work in our communities and at that policy level as well. Again, I think no one is unaware that there's an overall shortage of affordable housing across the state. We at the Housing Coalition are very involved in tracking this issue, especially around the number of low-income housing tax credit units that are coming into the end of their affordability period. This is a very serious issue that we're tracking at the state level and engaging folks really at the state level about what we're going to do to be proactive about preventing units from falling out of their affordability period. And this third bullet here, again, looking at the cross-sector efforts, I think, one of the really key points that came out of the analysis for us was that, without intentionality for cross-sector strategies, our social service systems are not really collaborating to the level of being able to leverage resources. And then at times we find that programs are competing for resources. And I think anybody that's working in the nonprofit world doing something within human services has had that experience, right? And then finally, we're seeing that sort of an inconsistent level of understanding around evidence-based practices in serving these two populations. And so I think that's really fertile ground going forward for educating folks around the state about what really does work, both to save lives, to help people access housing, and to help people thrive in housing as well. And then, so just to let you know, our next session is going to be Friday, January 12th. We'll do it again from 10 to 11:30 a.m. And we're going to feature colleagues from the Wilson Center for Science and Justice at Duke Law. So I'm really excited to have them come and present in January. So be on the lookout for the registration email. We'll also post about that on our website. And without further ado, I'm going to hand it over to our colleagues at the North Carolina Healthcare Foundation. Thanks.
All right. So I think we're good to go now. Yeah, so good morning, everybody. Before we kind of get started with our presentation, we just like to, thank the coalition for allowing us to present during the Learning Collaborative series here, and just giving us the space to really talk about a lot of the amazing opioid work that we kind of have going on here. So next, I just kind of like to briefly introduce our team this morning. So I'm Tevin Jenkins, and I serve as a project coordinator here within the foundation. And here presenting alongside me are Madison Ward Willis, who serves as our planning manager, and Jessica Foster, who serves as our senior program manager for the opioid work. And so next, I'll just give you a brief introduction to both NCHA as well as NCHF. So the North Carolina Healthcare Association, or again, NCHA, represents more than 130 North Carolina hospitals, health systems, physician groups, and other healthcare organizations. NCHA works alongside these member organizations to improve the health of North Carolina communities by advocating for sound public policies and collaborative partnerships, and by providing insights, services, support, and education to expand access to high quality, efficient, affordable, and integrated healthcare for all North Carolinians. The North Carolina Healthcare Foundation is the charitable nonprofit, innovative, and programmatic arm within NCHA. And as a convener of change for a healthier North Carolina, we work to power system-wide healthcare solutions, redefine healthcare delivery systems, and improve the health and well-being of patients in North Carolina and beyond. And so during the rest of today's presentation, our plan is to give you all some more information on the objectives of our opioid programs. So first, we'll spend some time covering our ED buprenorphine pilot project, followed by an overview of our ED peer support pilot project. And finally, we'll orient everyone to our opioid resource library. And so really getting into those opioid program objectives, each of our efforts in the opioid space kind of revolves around supporting health systems with one or more of these core objectives. So these objectives include, by advancing alternatives to opioids, accelerating the adoption of best practices, and improving care continuity and coordination among our hospitals and community partners, we hope to mitigate the opioid crisis, here in North Carolina. And so next, I'll hand it over to Madison to just kind of give some more background on us.
Thanks, Tevin. Good morning, everyone. So just wanted to, before we jump into our current work, wanted to highlight a few of our previous initiatives and resources that the NCHA has produced over the years. So when the opioid crisis hit North Carolina, back in 2017, NCHA convened a group of stakeholders from across the state and formed the Coalition for Model Opioid Practices and Health Systems. And the purpose of this group was really to drive strategy on how hospitals and health systems could provide high quality care for patients coming in with an overdose or substance use disorder, and also stop the overprescribing of opioids and then prevent future opioid prescribing in hospitals. So from 2017 through 2021, the coalition created the following resources. These are all available for free and located on our website. And just a few of the resources I wanted to highlight include a healthcare worker diversion toolkit. So this toolkit contains information and best practices to prevent and respond when a healthcare worker is experiencing a substance use disorder. We have the standard opioid prescribing schedules toolkit, and this was developed in partnership with UNC Health to ensure safe prescribing of opioids by really taking the guesswork out of it and providing standardization across 90 SOPS populations that include surgical, primary care, emergency medicine, to name a few. And then we have patient and provider journey maps that we used a process called patient journey mapping. These were created to really understand interactions, thoughts, challenges of chronic pain patients and the providers who care for them, and understanding what non-opioid therapies are available across North Carolina, where there are barriers, and then some opportunities for improvement. And then last, just want to mention that the coalition also, in its time together, worked with partners really across the country to produce several patient education materials on opioid education, alternatives to opioids, tapering, and pain management. So those are all, again, available on the NCHA website, open to the public for free. So I hope you'll check those out after this presentation. And I think I'm going to turn it back to Tevin.
All right. Yeah, so I believe we have some just some brief polling coming up next. Right. So the poll should be active. So of course, feel free to, go through and make each of your selections. All right, so we'll just give everyone just a few more minutes with the questions here. All right, so hopefully everyone has kind of had a chance to, roll through and take a look at each of the questions in the poll. During the next part of our presentation, I'd like to hand it over to Jessica next to kind of speak about some more of our ED buprenorphine pilot.
Great, thanks, Tevin. And just looking at the poll results, it looks like a lot of folks from the healthcare sector, housing, justice, harm reduction, social services, most people from the central region of the state, though we've got some folks from eastern and western as well. It's great to see 80% say that medications for opioid use disorder are accessible in your community. And in terms of peer supports, 70% are saying peer supports are also available in your community to assist individuals with opioid use disorder. So this is great to see and to kind of have a better understanding of who we have here as part of the Learning Collaborative and what frame of reference you're all coming from. We just wanted to acknowledge here, as Alex was alluding to, that there are many types of organizations that can be entry points to treatment and recovery and part of that ecosystem of care that supports patients along the way. So not only your traditional healthcare providers, but also the housing and justice community, faith-based organizations, community-based organizations. So although we're focusing in today on the hospital and health system piece of this puzzle, all of these types of organizations play an absolutely critical role. And ideally, we're working together and collaborating to support those patients with opioid use disorder. So as you all are probably aware, the opioid epidemic has been going on for some time now in North Carolina and nationally, and data suggests that although it is evolving, it is not getting better. So opioid deaths in North Carolina increased 22% in 2021 to a record high of 4,041 people who lost their lives that year. And in 2022, provisional data suggests that more than 11 North Carolinians died from a drug overdose every day. More than 77% of the overdose deaths in 2021 likely involved fentanyl, often in combination with other substances. So fentanyl is a potent synthetic opioid for severe pain management that's about 50 times stronger than heroin and 100 times stronger than morphine. So we're now in what's often referred to as the third wave of the opioid epidemic. The first wave being increase in prescribing of opioids in the 1990s, with overdose deaths primarily involving prescription opioids. The second wave began in 2010 with the rapid increases in overdose deaths involving heroin. And then the third wave began around 2013, with significant increases in overdose deaths involving synthetic opioids, and particularly those involving illicitly manufactured fentanyl, which is often found in combination with heroin, counterfeit pills, and cocaine. So with all of this in mind about the trends of the opioid epidemic, we know that individuals experience opioid use disorder who are justice involved or who are experiencing housing insecurity are especially at high risk. Studies have shown that former inmates with opioid use disorder are particularly at risk during the few weeks after being released. And similarly, those who are homeless are more at risk for overdose death than those with stable housing. Health systems have an immense opportunity here to play a large part in curbing this epidemic, and they, along with the local communities across North Carolina, have been working on wide-ranging solutions to address the opioid crisis. So the programs we're going to describe today aim to better support all patients with opioid use disorder, but especially these vulnerable groups, by accelerating adoption of evidence-based treatment strategies among hospitals. So the first program we're going to talk about, as Tevin mentioned, is emergency department-based initiation of buprenorphine. This has been shown to increase engagement in outpatient treatment and reduce the risk of subsequent opioid overdose. And then the second program is the use of peer support specialists in hospitals. Studies have shown that when peers are part of hospital-based care, the results indicate shortened lengths of stays, decreased frequency of admissions, and a subsequent reduction in overall treatment costs for patients presenting with behavioral health issues. So diving right into the ED-initiated buprenorphine pilot project. For those who aren't familiar with it, buprenorphine is one of several types of medications for opioid use disorder, or medication-assisted treatment, which is FDA approved for the treatment of opioid use disorder. Studies show that people with opioid use disorder who follow detox with complete abstinence are very likely to relapse or return to using the drug, which can, of course, lead to fatal overdose. So to help maintain abstinence from the prescription or illicit opioids, someone in recovery can use medications for opioid use disorder, which reduce the negative effects of withdrawal and reduce their cravings without producing the euphoria that their original drug of abuse caused. So to get a little bit into the clinical component of it, it's a partial opioid agonist, which means that it binds to the opioid receptors in the brain, but it activates them less strongly than full agonists do. That means, as I mentioned, it can reduce cravings and withdrawal symptoms in a person with an opioid use disorder. Studies have shown that there are many benefits of buprenorphine among patients with opioid use disorder that are shown here. It includes lowering mortality, better retention in outpatient treatment, decreases in hospitalizations and emergency department visits, as well as decreases in infectious diseases that can affect people who inject drugs. So because of all of these benefits shown here, medications for opioid use disorder, such as buprenorphine, are really the gold standard for treatment for patients with opioid use disorder. So an emergency department visit can be an intervention point where patients can be introduced to buprenorphine, help them start their recovery journey if they're ready, and serve as a bridge to that ongoing treatment in the community. So with that in mind, the North Carolina Healthcare Foundation worked with a small group of pilot hospitals this year and provided training, coaching, and technical assistance to help them administer and prescribe buprenorphine in the emergency department, improve community linkages to care for the patient so that they could receive ongoing treatment in the community. And ultimately, when we wanted to test and refine the tools and strategies that this group of hospitals used as they were implementing this treatment program and disseminate those resources across the state. So we developed a toolkit that you see here. I'll share the link a little bit later, that serves as an implementation guide to help North Carolina hospitals start an ED-based buprenorphine treatment program in their facilities. This project was also similar to the Housing Coalition's project. We were also funded by the North Carolina Division of Public Health Injury and Violence Prevention Branch. So here you can see the hospitals we worked with between roughly January through July of this year, as well as our partners who delivered the coaching and technical assistance to support these emergency departments with implementing a buprenorphine program. The pilot hospitals were distributed across the state, though, with most of them being in the central and western part of the state, and they also included large health systems as well as small rural critical access hospitals. This next slide shows the framework or the different phases of this project. So starting first with readiness, we began with assessing and understanding where the hospitals were at the beginning of the project and what the key components were needed to have in place for them to be successful. And then implementation, which was really the bulk of the work. So training and coaching on how to implement and standardize a buprenorphine induction workflow in the emergency department, including providing harm reduction tools as part of that workflow at discharge. We provided guidance for care continuity to help connect patients to ongoing treatment after discharge, including how to identify community partners and establish a referral process. We worked with the hospitals on data collection and measuring outcomes so that emergency departments could share the impact of their program with stakeholders and identify areas for improvement. And of course, ongoing iteration and continuous quality improvement once the program is implemented. So the toolkit that I mentioned really guides hospitals through each of these phases as they introduce buprenorphine in the emergency department. So this is the detailed workflow we recommended for the pilot sites. It was adapted from multiple sources, including UNC, the American College of Emergency Physicians, and Yale School of Medicine. And it walks through the essential steps in the process, which in some cases, the hospitals kind of modified this based on their own unique workflows within the emergency department. But the essential steps are the same across hospitals. So starting with screening for opioid use disorder and any comorbidities or contraindications. Second is assessing the patient readiness for treatment. So understanding where they are in their journey. Sometimes folks are ready to receive treatment, sometimes they're not. So having that conversation with them. Then assessment of their opiate withdrawal. So this is a prerequisite for being inducted on buprenorphine, is being at a certain level of withdrawal. So using the clinical opiate withdrawal scale to understand their level of withdrawal, and then administration of the buprenorphine if it's indicated, reassessment of withdrawal symptoms and a second dose if their withdrawal is persisting. And then finally, once they've stabilized, linkage to community resources for continued care, a bridging prescription for opioid use disorder, buprenorphine, and harm reduction and education tools are provided as well. So you can find the full workflow and the toolkit by using this QR code or the link on this slide. In terms of outcomes, this slide shows the impressive progress that the sites made in aggregate from January to July as they implemented this program. There were some data limitations, but even though this was a very short time period to be able to implement and observe results, we saw the aggregate trend was that the screening for opiate withdrawal, as well as the administration and prescribing of buprenorphine, increased during this time. So it was really wonderful to see that more patients were able to access this treatment through hospital emergency departments by the end of this project. And finally, we took a look at the aggregate results on the last slide. We wanted to highlight a few of the many hospital success stories from this project. So all of these facilities shown here are now able to administer and prescribe buprenorphine from the emergency department and have successfully established referral relationships. So at Wilkes Medical Center, as I mentioned, they're prescribing and administering buprenorphine from the ED. They also have grant funds available to help patients interested in MOUD and need financial assistance. They have peer support specialists in the ED to help patients through the process. And they made connections with both a doctor whose clinic holds spots for patient referrals from their ED a couple of times per week, and another clinic, Mountain Health Solutions, accepts their referrals as well. At Cone Health Women's and Children's Center, they're prescribing and administering buprenorphine to expecting moms interested in seeking treatment. So this is an OB triage unit. Referral relationships are established with a doctor at the Cone Health Women's Center and at another facility as well. And then finally at Hugh Chatham Memorial Hospital, they're prescribing and administering buprenorphine. Their ED conducts warm handoffs to peer support specialists, and they have a relationship with the Surrey County Office of Substance Abuse and Recovery. They partner with the paramedic team to help patients with transportation to their appointments for MOED that live within Surrey County. So a lot of excellent outcomes that the pilot hospitals achieved in improving access to buprenorphine. And going forward, we're planning for additional learning collaboratives, training, technical assistance, and coaching opportunities in the coming year to continue to support these and other health systems that want to start or expand their buprenorphine programs. So with that, I will turn it over to Madison to share about the peer support pilot project.
Thanks, Jessica. So the peer support pilot project is a historical project as well, kind of with the suite of projects I mentioned earlier. And I had the honor of working on this project in 2018. So I'll talk about a little bit about the project and then some of the outcomes, and also part of the project was creating an implementation guide. And so since 2018, lots of hospitals and emergency departments across the state have worked to embed peer supports in their ED or inpatient units, outpatient clinics. This is just going to highlight 6 hospitals that we partnered with, and one model of many that you can use for embedding peer support specialists into the hospital. So in early 2018, the North Carolina Healthcare Foundation learned about really innovative work happening at Atrium Health Wake Forest Baptist, embedding peer support specialists into their emergency department and other parts of the hospital, and really beginning to see great success. And so I think everyone here knows about peer supports with the poll, but just to be clear, that peer supports are folks who are living in recovery with mental illness or substance use disorder and provide support to others who can benefit from their lived experience. And as Jessica alluded to, we know that emergency departments are a really great entry point for care, and they're also uniquely positioned to effectively change attitudes, practices that define culture of substance use disorders. So with support funding partnership from the Division of Mental Health, Development, Disabilities, and Substance Abuse Services, this pilot project was formed. And the ED Peer Support Project launched in May of 2018, and we used Atrium Health Wake Forest Baptist, their model, and they were really kind of providing expertise and clinical support and technical assistance to the other 5 sites across North Carolina. You can see, like Jessica kind of mentioned, we also had a wide variety of different hospitals across the state. Sites were selected through a competitive RFA process, and none of the sites that we selected besides Wake Forest Baptist had an existing peer support program. So we wanted sites, we wanted really to see the whole process from beginning to end and learn about the process as we went. Goals of the project, really wanting to make sure peer support specialists were able to walk alongside patients who presented to the ED either with an overdose or use disorder. Originally, when the grant first started, it was specific to opioid use disorder, but we learned very quickly that, it's really hard to tell someone who comes into the ED, we can only serve this population. So we broadened that category to anyone with a use disorder. Connect patients to existing community resources like harm reduction, housing, social services, through warm handoff protocols. And then we hope by doing so that this would decrease future ED utilization, hospitalization. And then another goal was really to learn about this model and how it works across different hospitals, and most importantly, how it benefits patients. So a little bit of the kind of outcomes of the project. At the conclusion of the pilot project, as you can see, Pierce had served a total of over 5,000 patients and made a total of just over 2,000 warm handoff referrals. And one site maintained really great details, records about patient outcomes following peer support, and reported that after 30 days, after meeting with a peer, 65 of the patients who they contacted who didn't have permanent housing reported that they had obtained permanent housing. And this was all thanks to the peers and partnerships created in the community through their hard work and partnerships built. And then you can also see that of the overall referrals across sites, 469 of those were referrals to medications for opioid use disorder. And then among patient participants across all the sites, the total ED visits decreased by 40%, hospitalizations decreased by 56%, and 30-day readmissions decreased by 34%. So kind of as this pilot group was learning from each other and continuing to see some success across sites, we began to get questions from other hospitals wanting to learn more about this model of peer support or try to have a peer support in their hospital. And so we believe they're really key components to setting up a peer program for success. And we wanted to capture what we believe are really foundational pieces for an ED peer support program. And so we wrote this implementation guide. And the guide was written by the Healthcare Foundation along with Wake Forest Baptist and informed by all 6 of the pilot sites. And the guide includes key considerations, resources for the HR department, including sample job descriptions, education and workflow suggestions from 3 different EDs, protocols for screening patients, funding a peer program, and then the guide is also filled with quotes and stories from both the peer support specialists and some of the other clinicians that worked on the project. And so you can find this resource along with all the others we mentioned in our online library for opioid stewardship. And I think Tevin is going to talk about that right now.
Yeah, thank you, Madison. So yeah, just really jumping into our opioid resource library next. So earlier this year, we launched the resource library itself through our affiliate organization, Cara Nova. And really the goal of this library was to simplify access to existing best practices, tools, and interventions, and really accelerate their adoption across the Carolinas. And so really through frequent collaboration with a team of subject matter experts from both North and South Carolina, we're able to compile various tools and strategies that all aim to support health systems with implementing evidence-based OUD prevention, facilitate harm reduction, treatment and recovery strategies. And so as you can see kind of on screen, a few examples include national guidelines from the CDC, SAMHSA, and the American Society of Addiction Medicine, as well as some resources developed by state and local organizations. And so I think next we were going to kind of take you guys through the library itself, just to kind of briefly walk through some of the resources that we kind of have available here. So if you go under the medications for opioid use disorder banner, there we go. You'll find the emergency department buprenorphine treatment, a toolkit for North Carolina hospitals. There we are. And again, all these resources are readily available. We've all kind of compiled them here, and you're all free to, really go into them, open them up, and really sink your teeth into all of them. And so if we go back to the library page and take a look under the peer supports banner. All right. You'll also see the ED peer support implementation guide here. And of course, same deal as last time, to open up a PDF for you guys to really, take your time and pour through a lot of the information that we kind of have, really gathered here for you. All right. And so also on the resource library website, you'll notice that each of the resource pages has a state icon, which indicates if that tool or resource is aligned with either South Carolina or North Carolina opioid settlement fund strategies. Right. And so really just going back to our homepage here on the library, if you scroll to the very top, you'll see the technical assistance tab, which has information about, various technical assistance opportunities, including a request for applications that we just issued to invite hospital emergency departments to apply for support with implementing ED-initiated buprenorphine treatment. Under this tab, you'll also see we have a general TA request form set up so that any hospital in North or South Carolina can use to submit a request for implementation assistance associated with the resources and the strategies that, again, are kind of compiled here in the library. Right. And I think that was toward the end of our slides. So next, we'll really open it up for lots of Q&As and just open up the space for more discussion.
Awesome. Yeah, thanks, y'all. That was really great. We have a couple of questions in the Q&A. The first question is, how is NCHA working to connect with opioid treatment programs and access to methadone?
Yeah, so this was a key piece of the ED buprenorphine pilot, that connection to community-based providers. So really NCHA's role, as well as our technical assistance partners at Mountain Area Health Education Center, work closely with the hospitals to identify who are those outpatient treatment providers that are in the community that are able to accept referrals. So as part of that toolkit, when you take a look at that, a big component of that is how do you find those partners, and how do you establish that referral process? What are the questions that need to be asked for that warm handoff to occur? And so in some communities, it might be an OTP, and others it might be an FQHC. Others of the larger health systems had outpatient providers within the health system that were able to accept patients. So it's really kind of individualized based on the hospital and what resources were available in their community. But our goal was to kind of provide the tools and the coaching support to help them identify those partners and to be able to make those warm handoffs and referrals.
Thanks. And then kind of related to that, are there any concerns that have arisen with the technical assistance? So, how can we continue to close the gaps in service for individuals that end up in the emergency department?
Yeah, so I think a lot of the focus that we had as well with the ED buprenorphine pilot, at least, and I'll turn over to Madison in a second to see if there's anything different with the peer support pilot. But I think initially it was kind of working with the champions at the hospitals and health systems that were identified to make sure that education and training was provided across the emergency department staff. There are varying levels of understanding about how MOUD works and the benefits and how to administer and prescribe it. So that was a big piece of the implementation, was just making sure that all of the clinicians had an understanding, were on board with the workflow, and that they knew what to do when a patient presented who was a good candidate for this treatment. And then once that was established, I think the major areas that we got questions about and had to work through with the hospitals were related to finding those community-based partners, just because there is, I think, with the workforce shortages that exist across behavioral health, just in general, kind of a lack of capacity in many communities that provide the community-based treatment, and making sure that they had the harm reduction tools to provide a discharge. So providing those naloxone kits, making sure that patients had harm reduction education. Those were some of the other common questions and issues that came up through providing the technical assistance. Madison, was there anything you'd add from the experience of the peer support?
No, well, the only thing I'll just echo is really that education to the emergency department staff, and how sites really said that was almost a bigger outcome than anything from the pilot project was culture shift in the ED, when having peer supports come on board and really work right alongside the physicians and clinicians across the department, how that shift in the ED and the kind of stigma breakdown was enormous. But nothing else to add.
And then sort of related to that, do you see, barriers at, say, like the state level or sort of system level with adoption or understanding of these evidence-based practices? One of the things that's kind of come up, at the community level, right, is like there's a group in Durham that is, we're engaging recovery housing providers who've been traditionally abstinence only around, the benefits of MAT and MOUD. I'm wondering, from your perspective, kind of more at that kind of systems level, sort of above the community level, do you see barriers kind of with greater adoption, or do you think people are starting to really understand the benefits of these interventions?
I think a lot of progress has been made. A couple of the historical barriers are starting to go away with Medicaid's expansion, as you mentioned. I think a lot more of these patients, many of these patients are uninsured and will be able to get coverage through Medicaid. So I think that'll lead to some great improvements. And also the recent elimination of the X waiver, which was previously required in order for providers to prescribe buprenorphine. There used to be a lot more kind of administrative requirements in order to provide this medication to patients. And with that X waiver being gone, I think that's kind of reducing some of the barriers as well. And with the opioid settlement funds promoting use of evidence-based practices, I think that's also helping getting the word out. More counties and communities are educated about what the evidence-based practices are, and able to, of course, access funds for those. So I think a lot of progress is being made in that area.
There's another question about the data collection. So how was data collected for people that did not initiate buprenorphine because of concern for precipitated withdrawal? That might be a good candidate for methadone. There wasn't a mention of methadone in the data shared in the webinar. And is methadone listed in the opioid library?
So we haven't had a huge focus on methadone. We've primarily focused on buprenorphine, using many of the workflows that are available and adapted from kind of national sources, and working with subject matter experts on that for the ED induction component of that. So we didn't really collect that data as an association. Certainly the hospitals may have some of that data from their EMRs around patients who did not initiate buprenorphine. And it certainly is the recommendation that those emergency department clinicians need to work with those patients to understand what is the best course of action for them, whether it's buprenorphine or methadone or no MOUD at that time. The individual clinical assessment needs to be made to understand what's best for that patient and what their preference is. So we don't have currently a lot of resources specifically around methadone, sort of more about MOUD generally, as well as buprenorphine specifically. But that's certainly an area that we could look to expand into as we look to improve the resource library.
There was also a comment about the country being in a fourth wave with adulterated drug supply with things like xylazine. I'm curious, as sort of the drug supply changes, and obviously medical and public health professionals kind of have to keep up to understand what's happening. I'm wondering if you can talk a little bit about like that translation from the sort of the medical side, public health side, to how to communicate the dangers of the changing drug supply, from within the sort of a harm reduction approach to communities about what to look out for and how to kind of to help prevent overdose deaths or to keep people as safe as possible. Just curious your thoughts on that.
Yeah, I think hospitals and community-based providers are probably seeing these trends before anyone else is, really, because they're on the front lines of this. And I know that the protocols, coming out from the American College of Emergency Physicians and other groups that are working to provide, continued medical education to those folks, are evolving and adapting their guidance around treatment of opioid use disorder to take into account fentanyl, xylazine, and these emerging issues that are coming up. So I think through all of those channels, providers are having to evolve their protocols to make sure that they're appropriately treating those patients. And if others are seeing effective ways of addressing that, would be interested. I don't know, Alex, if you've seen anything in your experience working with the housing community as to how that's coming up.
Yeah, that's a great question. I have not really heard specifically from sort of like the housing perspective about this, but there were definitely a couple of comments about how like the rise of xylazine, and I might be mispronouncing this, nitazine, makes buprenorphine more difficult to initiate, and that also treatment for xylazine is different from traditional wound care. So I'm wondering if at this point, if folks want to make comments live or continue questioning live, if you want to raise your hand, I can unmute you and we can have more of a discussion, or if folks have any other questions that they want to put in there. Okay, I see Dave has raised his hand. Let me just unmute Dave. All right, Dave, go ahead.
Yeah, I was just going to add to your comment about xylazine there. I know just personally administering Narcan, xylazine, usually you don't always get consent for Narcan, but xylazine, there's like, I mean, you're giving it to a zombie, which is a little more traumatic, I think, for the giver. I don't know if it's necessarily more traumatic for the receiver, but when you can't get any sort of anything and you're just kind of yelling at somebody and you're like, well, I'm gonna shove this up your nose, buddy, good luck. It is just a little more, it feels more obtrusive. So I know xylazine's pretty heavy in our neighborhood right now, and you don't see the results. That's the other thing that I think happens. You shoot somebody with Narcan and they're still going to get loaded up in the ambulance and go, and you're not going to know if they come out of it or not, because the xylazine still has them basically kind of comatose or So I don't know, it's it's a lot less satisfying. As weird as that sounds, right? Narcan kind of seems like it's almost like you resurrect somebody when you give it to them without xylazine, but with xylazine, there's still like the community's still in doubt. Somebody loads up in the ambulance and you don't know if they made it for a couple of days until you hear from a family member or something. So just from a community trauma standpoint, it's a lot more complicated.
Yeah, thank you. Sarah wants to make a comment. Sarah, go ahead.
Thanks. And just to follow up a little bit about Dave's comment, I think it's also just as traumatic on the individual. Xylazine is not well known right now, and people don't always know some of the side effects of the adulterated drug supply. It can create massive wounds that are hard to treat. There's a lot of shame and stigma associated with it when they're going in, to regular healthcare providers or their primary care provider. And to be frank, they're not always primary care first initiation, I guess first initial visit. They're not always prepared to address that kind of issue. So I think that also plays into housing because with these large wounds, people don't want to leave their homes, so they don't even want to talk about what's happening. So I'd say it's also the individuals experiencing a significant amount of trauma as well.
And Sarah, maybe just for clarification for folks who don't know, can you just quickly explain what xylazine is?
Sure. Xylazine is typically used as a veterinarian tranquilizer, and it's been just down the line as people have used heroin. The drug supply has been so adulterated with fentanyl and other types of chemicals that they don't always know the long-term effects of that. That if you give someone Narcan and they start breathing, but they're not resurrected, as someone said, they're still alive. They're just sedated. So it's very similar to just actually being tranquilized. So once they come around, that experience. We haven't done any kind of research. We don't know how people feel after that. But it, like, getting that information out into the community, just that, like, even the parts about the wound care is different, I think is really important because if we can't even get our doctors to understand how to treat the wounds like almost like chemical burns, then it's hard for people to then go out and seek other support services because they're embarrassed.
Yeah, thanks for that. Any other folks that have questions or comments for our panelists? One other question. I mean, Jessica, you had alluded to, Medicaid expansion a little bit earlier. Just curious, like, what other benefits do you see with Medicaid expansion that are going to come down in the next couple of months that will help this work?
Yeah, I think, again, just having those patients covered, getting the additional funding to hospitals and communities, I think will really help bridge that gap. I know that hospitals having initiated buprenorphine often have trouble finding that community-based provider who they can refer to, who will accept the patient. And I think really just having those patients covered by Medicaid will make a huge difference in their continued ability to get treatment.
Arthur, go ahead.
So one of the concerns, and I am a program director for an opioid treatment program. So one of the things that we're hearing on our side is that folks are having trouble getting their buprenorphine filled that have successful prescriptions. And I'm wondering at pharmacies. So I'm not sure there's an answer, but that's even more reason for us to not discount that there are multiple medications for the treatment of opioid use disorder, and buprenorphine is a great product for the right person. But if we're not presenting all of the options, including the injectables like the Sublocade and the Vivitrol and things like that, you know, the data that makes it a gold standard for treatment are the 3 FDA-approved medications. So there feels like a disservice when not all 3 of them, not all 3 options are there. You have the listing of the TIP 63, which clearly says 2 agonists, 1 antagonist, but none of that data is shown in the hospital systems. And I know it's a heavy lift for EDs. I'm grateful that they're dealing with this differently than they have in the past. But we need to do better education across the medical field because I know there are people that are not getting the ED, the PORT teams, the post-overdose response teams, and we have to be able to say buprenorphine is a great medication. How else can we solve this, including people who choose abstinence-based? We can't have one solution and that be the only path, because we will automatically exclude 3/4 of people. So thank you for letting me listen.
Yeah, I really appreciate those comments, Arthur, and 100% agree that we don't intend to present buprenorphine as the only option. I think as we're working with hospitals and health systems, many of who have not traditionally provided treatment such as this to patients, there's sort of a glide path to being able to offer these services and learning about what options are available. And so I think that kind of goes back to the importance of that cross-sector collaboration that is so critical, where if the ED is able to initiate the buprenorphine, but also be able to educate the patient about the different options that exist in the community. And if methadone is indicated or some other option, to be able to connect that patient to what is best for them, to the OTP in the community, or to other organizations that can support them on their journey. I think that's very important to keep in mind, that this is not the only treatment pathway, that other options exist.
So we just have a couple minutes left, so I think we could take 1 or 2 more comments or questions if anyone has any. And then if not, like I mentioned before, we're recording all of these sessions, so we're going to make them available on our website so you can share with your colleagues who weren't able to join, or if you want to refer back to something that was said, you can do that. And also, as I mentioned as well, we're going to send out the slides as a PDF to you in the coming weeks. So just bear with us as we get that prepared. And then finally, remember that the next session will be January 12th. That's another Friday from 10 to 11:30. Again, you'll get that email blast from me. You also get it off of our website, and we look forward to having more folks join. And I just want to thank Madison and Jessica and Tevin so much for taking the time to present this really wonderful information to us and all of their work. You've got their contact information there on the screen. Please feel free to reach out to them. Let me just put my email in the chat if for some reason I haven't done that. I should have done that earlier. I'd love to hear from you, just your thoughts on the series. What you think went well? What can we improve going forward? As I said, we're going to cover a lot of different topics over the next 5 sessions that we'll do. So again, thank you all so much for taking the time on a Friday, on a holiday, to be here with us. I really appreciate it. And looking forward to having you come back in January. So thank you all so much, and have a great weekend, and see you soon.